Okay, so when we're talking about the congenital heart disease in peds, the most common ones is the ventricular septal defect. They account for 30% of the total cases of the congenital heart diseases. Okay, and among these VSDs, we have three main types, but according to like different books, total four types are there. Okay, and membranous, muscular, perimembranous, and infundibular. The membranous one is most common. It accounts for 90%. So VSD is the most common congenital heart disease, and among the VSD, membranous type is the most common one. Okay, and then we have the muscular one. They can be multiple, and they create a pattern known as the Swiss cheese pattern. Now, what is the infundibular type? It is present just below the pulmonary valve. And what about the perimembranous? Okay, perimembranous type, I found this in the MCQs that perimembranous type, first of all, it is present adjacent to the tricuspid valve. This is written in the illustrated textbook of pediatrics, that it is present adjacent to tricuspid valve. And in the MCQ, I found out that this perimembranous one has a conductive tissue running in its inferior margin. Why is this point important? Because during surgery, if you are suturing a patch on that defect, you have to be careful not to touch that inferior area of the conductive tissue. Otherwise, you are going to, affect the conductive system of the heart, and arrhythmias and severe issues can occur. Okay. Now, so this was the MCQ point. The MCQ was muscular VSDs do not have conductive tissue running in their inferior margin. Okay, which ones have them? The perimembranous. They have conductive tissue running in their inferior margin, and you have to avoid that conductive tissue during surgery. Now, 30%, yeah, we get it. Now, the subacute bacterial endocarditis prophylaxis is required, but only for specific type, not for all, but we do perform it. Now, very important thing, when does the murmur occur? It is not going to happen during the first 24 hours. Why? Because initially the pulmonary resistance is high, so flow is not going to be significant between the ventricles. Okay, and surgery is done between 3 to 5 months, and there is something called interventional catheter closure. It is not done, but it was an MCQ option, so I'm discussing it, and it is done rarely for small defects at a higher age. Not important. Now, the main point that you should know is smaller VSDs and larger VSDs. Now, smaller VSDs are very harmless. Why? They're harmless, but they're loud. People who say what's on their mind, they show their plans, so they're harmless. But people who are always, they stay quiet and you don't know what's going on in their brains, they are much, much more dangerous. So the smaller ones are harmless because they give a very harsh pansystolic murmur. Why? Because since the VSD defect is small, so, blood flows with a lot of friction, so a very large murmur is heard. And S2 is soft. Why is S2 soft? Because the pulmonary portion is unharmed right now. There are no pulmonary changes. So the pulmonary component of S2 is normal. And they close spontaneously. So you don't have to do anything. But large VSDs are the issue. They cause heart failure. When? This is the MCQ. When do they cause heart failure? After the first week. So one MCQ point is that they do not cause an audible murmur during the first 24 hours. Never. No matter if it is large or small. And large VSD lead to heart failure after the first week. So the child is going to present with symptoms of heart failure, tachypnea, tachycardia, palpable liver, and growth retardation after the first week. And what are the signs of heart failure? There is going to be left parasternal heave due to right ventricular hypertrophy. Soft pansystolic murmur is going to be there because the defect is very large. And we are going to have another murmur which is not present, a smaller defect, that is the apical mid diastolic murmur. Why? Because there is going to be increased flow during. So this apical mid-diastolic murmur is going to be there because of the increased flow across the mitral valve, and it's only going to be present for large VSDs, and a loud S2 is going to be there because pulmonary changes are going to occur. Cardiomegaly is going to be there. There is going to be right ventricular hypertrophy. Pulmonary vessels are going to be engorged. Pulmonary edema is going to be there. Okay. So these are the important points of VSDs, the MCQ points.